Hey, this is Doug, and I'm back with number 5 of 5 videos helping you get ready for ACLS. The purpose of this video is familiarization with the post-resuscitative care protocol, or post-ROSC. ROSC is a mnemonic for return of spontaneous circulation, a term we use now for return of pulse, essentially. The post-resuscitative protocol kicks in immediately after a cardiac arrest is stopped to determine that a pulse is present and that pulse is confirmed. The post-resuscitative protocol has 2 phases to it. Phase 1, we got this guy back to life, let's keep him alive. And phase 2, let's do things to try to improve his long-term outcome from the effects of this cardiac arrest. So under phase 1, I want to first talk about ventilatory support. During the code, if I'm the ventilatory person, one of 2 things has been going on. Either in the unprotected airway, you've done 30 compressions and you've paused and I've delivered 2 low pressure, low volume breaths, each 1 second long. Or if the patient has an advanced airway in place, like a supraglottic airway or an ET tube, you're doing continuous compressions and I'm watching the clock and delivering 1 breath at precisely every 6 seconds. But once the patient is resuscitated and you're no longer doing compressions, I can't just drop the bag and walk away, because rarely does a patient get a pulse restored and immediately begin breathing again at a life-sustaining minute volume. So I need to stay there and I need to do rescue breathing. Rescue breathing delivers appropriate breaths for the adult once every 5 to 6 seconds, 10 to 12 breaths per minute, potentially coordinating with the patient's own attempts to breathe to maintain good minute volume, ventilation, and oxygenation. Now, secondary to rescue breathing, if my patient has an oropharyngeal airway in place, or I have some other indication that the patient doesn't have a gag reflex, is not conscious, is not capable of protecting their own airway, and we have not yet established an advanced airway, then intubation becomes a top priority. I'm going to put ETT for endotracheal tube. During the cardiac arrest protocol, if you watched that video, there was never a point in time where I said, here's where you must stop and put a plastic tube in the patient's trachea. In a real code situation, if you've got somebody on your team who is talented enough to drop an ET tube without interrupting compressions, then that's a marvelous thing to do, and it helps protect the airway from the potential of aspiration. But studies have indicated that if the placement of an ET tube requires interruption in compressions, it hurts the patient's chance of resuscitation, so that is not indicated in that situation. However, after resuscitation, we're not doing compressions anymore. If that patient can't maintain their own airway, then ET tube becomes a top priority. Plus, a secondary benefit of having the ET tube in place is that you can pull in mechanical ventilation. By pulling in the mechanical ventilator, I can do 2 things. I can take that nurse or respiratory therapist or anesthesiologist and I can relieve them from that duty of bagging that patient, and they can go do the other stuff they've got to do that day. But also with mechanical ventilation, I can titrate those ventilator settings very finely to accomplish what I want to do. And what I want to do is I want to start normalizing his blood gases. We're going to get ABGs back on this patient, and in most cases, from a patient in prolonged cardiac arrest, what we're going to find is respiratory acidosis. Now, past protocols addressed respiratory acidosis by giving boluses of bicarb, and that is not the best way to treat that. That's the way you treat metabolic acidosis. Respiratory acidosis should be treated with titrated mechanical ventilator settings. So for temporary time periods, we may increase our respiratory rate, our respiratory volume, and our PEEP in order to blow off all that excess CO2, but titrating those ventilator settings up or down based on the patient's blood gases, with the optimization of normalizing those blood gases as our goal. At the same time that we're doing these ventilatory resuscitation steps, we also want to do things to support circulation. Many patients after resuscitation are resuscitated with a low blood pressure. They're peripherally vasodilated. You want to address that peripheral vasodilation with fluids. The protocol recommends 1 to 2 liters of some kind of isotonic crystalloid solution like Ringer's or normal saline. and try to boost the pressure with that. Your target pressure is not 120/80. There's no reason to have the patient's pressure that high. There's no reason to stress the heart like that. Your target blood pressure is 90 millimeters of mercury. Your patient can perfuse every body system adequately at 90 millimeters of mercury with minimal stress on the heart. All right, so in phase 1, after resuscitation, we have a patient who is ventilated. He's on a mechanical ventilation. His blood gases are normalizing. His systolic pressure is 94, and we've brought the fluids back to TKO just for maintenance drip for the blood pressure. Now we can move to phase 2. Phase 2 has to do with improving long-term outcomes, specifically cerebral outcomes and cardiac outcomes. During cardiac arrest, your patient's brain was hypoperfused, and this brain suffered a hypoxic insult, which is not manifested during the cardiac arrest, but when blood flow is restored back into the cranial vault, that traumatized tissue swells, and the cerebral edema that results from a prolonged hypoxic insult to cerebral tissue produces permanent brain damage in many patients. A lot of patients are resuscitated back from cardiac arrest in a permanently vegetative state. So instead of resuscitating Doug, you've resuscitated another organ donor. Well, to mitigate cerebral edema after cardiac arrest, research scientists have tried corticosteroids, osmotic diuretics, and other treatments that have been shown to be effective in TBIs, but were not effective from cardiac arrest. What they did happen upon that was effective for treating the cardiac arrest patient is refrigerating the body. Dropping the body's core body temperature to 32 to 36 degrees for over 24 hours has been effective to the point to where in 50% of patients in some studies, there's been cerebral improvement. So this used to be called therapeutic hypothermia. Now it's called targeted temperature management, TTM. TTM is a protocol that involves dropping the patient's core temp to 32 to 36 degrees centigrade for at least 24 hours. The original therapeutic hypothermia protocols said for 12 to 24 hours. And what we found was that when we resuscitated patients from cardiac arrest and put them into this therapeutic hypothermia, and it worked, and the patient began to wake up and have improved cerebral function, we would terminate the therapeutic hypothermia before the 24 hours was over, and we would also shortcut the benefit. The patient's brain would swell again, and we'd end up with the same damage to the brain as we did before. So this minimum of 24 hours is very important. Some nurses that work in hospitals that I've talked to here recently said they often do this for 3 days and then have a 3-day warming period afterwards where they gradually bring the patient's temperature back up to speed. So it could be a total of 6 days that the patient's at least moderately hypothermic. The indication to put a patient in targeted temperature management to induce this hypothermia is in a patient who's not capable of responding to verbal commands upon resuscitation. So if they can't respond to verbal commands, they are a candidate for immediate TTM. Now the heart. The patient who's been newly resuscitated from cardiac arrest should be considered a candidate for the cath lab, PCI. If I come into your emergency room and I'm having a heart attack and I keel over in cardiac arrest and you do what you're supposed to do and you resuscitate me, I'm still having that heart attack. I need to go to the cath lab immediately. And so for most of these patients, and the indication to send them to PCI is the fact that you think that their cardiac arrest was cardiogenic. They could benefit from at least a diagnostic catheterization and coordinate that activity with the receiving cardiologist. And cardiologists have no problem receiving patients who are refrigerated. So you can do these two therapies, PCI and targeted temperature management, in concordance. We frequently send hypothermic patients to the cath lab. All right, that's the post-resuscitative protocol. Keep your patient breathing, normalize their blood gases, keep their blood pressure up with a target of 90 systolic, and then if they're not verbally responsive, get them in TTM. And if you think you've got a cardiogenic problem, send them to the cath lab. Thank you very much.